This is an introduction to the NH&MRC Lactoferrin Evaluation in Anemia of Pregnancy study, also known as LEAP-1. In 2000, the World Health Organization produced a report which stated that iron deficiency anemia reduces the work capacity of individuals and entire populations. Overall, it was the most vulnerable and the poorest and the least educated who were most affected by iron deficiency. And iron deficiency is the world's commonest nutritional disorder, affecting over 2 billion people. Women and children are at greatest risk. The global impact is summarized in some stark statistics, affecting about 56% of pregnancies in low-income countries, 12% of pregnancies in Australia, and in particular 25 to 40% of Australian Aboriginal women and children. If we take a look at the evidence from observational studies, which, by the way, do not allow us to make inferences about cause and effect, what we find is that iron deficiency anemia in pregnancy is linked with stillbirth, low birth weight, preterm birth, fetal growth restriction, neonatal mortality, and reduced iron status in mother and infant. Reduced iron status in the mother and infant is associated with impaired mother-infant interactions, impaired auditory memory at birth, suggesting hippocampal damage, irreversible psychomotor delay, and problems with low IQ, behavior, and poor school performance. And an important cohort study performed in Central America by Betsy Lozoff and her group showed that despite correcting anemia in early infancy, cognitive delay in the children who were affected persisted for more than 10 years. Another study showed that if you followed 5-year-old children who had had serum ferritin in the cord blood in the lowest quartile, less than 76 micrograms per litre, at the age of 5, they had inferior language and fine motor skills compared with their normal controls. And so this evidence raises the question as to whether there may be a window for adequate iron intake in antenatal and early postnatal life, just as there is for hypoxia and hypoglycemia. And further, once this window is closed, do we get irreversible negative programming as a result? Well, let's take a look at some of the evidence from randomized studies which do allow inferences about cause and effect. Here's a systematic review in the Cochrane Library of 43 trials in over 27,000 women who were randomly assigned to have daily oral iron supplements or no iron or placebo. And basically they found three main findings: that the women who were given iron supplements were much less likely to have low birth weight, 20% less likely to have low birth weight babies. They were 70% less likely to have maternal anemia at pregnancy, at the end of pregnancy. That's a 70% reduction in the risk ratio. And they were 57% less likely to have iron deficiency at term. But they were more likely to have hemoconcentration, defined as more than 130 grams per litre of hemoglobin, which itself has been associated with small for gestational age. Another systematic review in the Cochrane Library showed that in 23 trials in just over 3,000 women, these were women randomized who already had a diagnosis of iron deficiency anemia in pregnancy, and they were randomized to have oral iron or nothing, which may be ethically questionable these days. It was shown that oral iron did reduce maternal anemia, but none of these trials reported clinical outcomes in the children. And the authors concluded that it was unclear if treating mild to moderate anemia achieves net benefit or harm. So they recommended larger trials of different treatments, stratified by severity of anemia. Now, standard treatment with oral iron, oral inorganic iron supplementation, is basically suboptimal because it's very poorly absorbed and tolerated. And up to 80% of women have nausea or abdominal pain or gastric upset or constipation when they take daily oral iron, and as a result, about 50% may stop. As a pediatrician myself, I've been very well aware of the risk of accidental overdose when children, toddlers, find their mother's iron capsules and mistake them for lollies or sweeties. So it's very important that oral iron is safely stored because it can lead to a risk of accidental overdose in children, which can be life-threatening. There has been some important work done by our colleagues in Launceston in Tasmania in a randomised trial in which half of the women were randomised to receive intravenous iron and half were randomised to receive oral iron supplementation. And they found that normal iron stores, normal serum ferritin, were maintained in the intravenous iron group for 95% of the group until delivery, whereas only 20% of those receiving oral iron had normal iron stores at delivery. And very importantly, on 3-year follow-up, these groups showed that the iron infusion was associated with improved general health, improved physical energy, improved psychological downheartedness, less clinical depression, and improved mental component scale, and improved duration of breastfeeding up to 3 years later. So this brings us to the question of whether lactoferrin is a potential alternative treatment to standard oral iron sulphate or iron gluconate treatment in pregnancy. Lactoferrin is an iron-carrying immunomodulatory anti-inflammatory and antioxidant glycoprotein, which also promotes the growth of bifidobacteria in the gut. Lactoferrin is found in white blood cells, in the mucosal secretions, in sweat and milk and other exocrine secretions. And in fact, it's a key element of the innate immune response, which modulates inflammation and iron homeostasis. Bovine lactoferrin, which is the subject of our study, is a dairy protein which is 80% homologous with human lactoferrin. And our Italian collaborators, Rosalba Paesano and her group, were the first to publish reports of increased levels of IL-6, an inflammatory cytokine, in iron deficiency anemia of pregnancy, in this open-label study in which half of the women were randomized to have oral lactoferrin to treat their anemia, and half were randomized to have oral iron sulphate. And if we look through this slide, we find that the women who were randomized to lactoferrin were receiving only 8.8 milligrams of elemental iron per day. And after 30 days, their hemoglobin had risen from 100 grams per litre to 25% greater, to 125 grams per litre, a highly significant improvement. Whereas the women who were taking oral iron sulphate, even though it was 17 times the dose, 156 milligrams of elemental iron per day, their hemoglobin only increased from 100 to 110 grams per litre. In the oral lactoferrin group, serum ferritin rose from 11 to 34, a threefold increase, whereas in the oral iron sulphate group, serum ferritin did not significantly change. And in the oral lactoferrin group, serum iron more than doubled from 440 micrograms per litre to 940, whereas serum iron did not significantly increase with the oral iron sulphate group. If we look at what happened to the red cell count and the IL-6 concentration, we find that the red cell count increased significantly by about 25% in the oral lactoferrin group, whereas the red cell count didn't change significantly with oral iron. And the serum IL-6, the inflammatory marker and inflammatory cytokine, was 34 at baseline in the women with iron deficiency anemia, and it was reduced to 12 with oral lactoferrin, whereas it increased from 33 to 52 in the women who received oral iron sulphate. And I should say that IL-6 should be at around 1 nanogram per litre, so that at baseline these anemic women already had grossly elevated IL-6. They were in a significantly inflammatory state. If we just review that information in pictorial form, to summarize, the women who were randomly assigned to have oral bovine lactoferrin, their hemoglobin increased by 25%, whereas the iron sulphate group, the hemoglobin increased by 10% only. The oral lactoferrin group had a threefold increase in serum ferritin, whereas there was no change with oral iron sulphate. and the effect of lactoferrin on the IL-6 level, the inflammatory marker, was to reduce it from 34 to 12 with oral lactoferrin, but to increase it still further with oral iron sulphate. Now, our Italian colleagues were also the first to publish evidence that bovine lactoferrin actually enters the nucleus. And this is a series of slides showing that fluorescein-labeled bovine lactoferrin actually enters the cytoplasm and then the nucleus within about 3 hours in a human colon intestinal incubation model. So this raises the question of what may be happening. How may bovine lactoferrin modulate inflammation and iron homeostasis? And in fact, it's been proposed that bovine lactoferrin reverses hypoferremia, as we saw in the open label study by Persano and others, by entering the cell nucleus, where it actually downregulates the production of both IL-6 and hepcidin, a major iron regulatory hormone. And this in turn may upregulate ferroportin, which is the only known iron exporter from cells, and thereby enhance iron absorption from the gut through the enterocyte and release iron stored in macrophages and hepatocytes. And the net result of all of these is thought to be a substantial increase in serum iron concentration. Other evidence from Italy, from another group, was taken from a pilot study asking the question whether human lactoferrin may reduce some of the risk factors for preterm delivery in iron deficiency anemia of pregnancy. And this group performed a pilot study in 21 women with iron deficiency anemia, of whom 14 received a human recombinant lactoferrin twice daily for 1 month, whereas the other 7 received iron sulphate, 520 milligrams once a day for 1 month. And the group treated with human lactoferrin showed a reduction in cervical IL-6 secretions and an improvement in abnormal vaginal flora. This takes us back to the study that was done by our colleagues in Launceston and raises the question whether IV iron polymaltose may in fact have a greater role in future. However, it is, although more effective than oral iron sulphate, it is more expensive because it takes 5 hours and it does need supervision in hospital. Although I must say that our colleagues in Launceston did comment that many of the women were very grateful to have 5 hours of rest with a sandwich where they couldn't go shopping or do any housework. That was something that was quite appreciated. But we do now have evidence from the same group and from others that you can also correct iron deficiency anemia with a much shorter infusion of carboxymaltose over just 15 minutes. Its trade name is Ferinject. And this raises the question whether inorganic IV iron, like the oral iron sulphate that we saw from the open label studies from Persano and others, may also increase IL-6. And we think that's a very important question which we will be addressing in our study, the lactoferrin evaluation in anemia of pregnancy study.